Good afternoon, my name is Adeola. I'm a second year medical student. I've been asked by Dr. Liniam to take a cardiovascular and peripheral assessment on you. Is that okay? Okay. Just to let you know that everything we're going to do here today is going to be very confidential. Okay. Can you tell me your name, please?
My name is Mark.
Mark. Okay. And then your date of birth?
Date of birth, I'm 18th of August, 1978.
Okay. And Mark is just fine. Observation of the patient. I'm looking at the posture of the patient just to make sure the patient is relaxed. The patient is oriented to person, place, and time, no confusion. And I'm also looking at making sure the patient is breathing with ease and there is no distress in the patient. I'm checking the sternocleidomastoid muscle to make sure, and then making sure the patient is not breathing with distress at all. I'm also looking at the shape of the chest as well. I'm looking at the skin color of the patient just to make sure it's consistent with the cultural background. I'm also checking for any scar on the patient as well. And then I will check for the peripheral cyanosis on the earlobes as well, to make sure there is no cyanosis at all. And I'm also at the nose of its fingertips. And then for the central cyanosis, I'll ask the patient to open his mouth, please. And I'm checking the mucosa as well, the lips, and also checking there is no arching of the ear, arching of the palate, which might be indicative of any Marfan syndrome that might be ongoing as well. I will ask the patient to look up, and then I'll be looking at the conjunctiva for any form of anemia or any form of thalassemia, which might be indicative of lipid deposition in the patient as well. And then I'll come to the hand of the patient as well, and I will be checking the nail beds as well, and checking for capillary refill for at least it should return for 3 seconds, and I'll do the same on both sides as well. I'll be asking the patient to show if there's any form of clubbing as well. It should be less than 180 degrees in the patient. Again, checking the nails for any splinter hemorrhages that may be indicative of any, to rule out any endocarditis, infected endocarditis. I'm also checking at the palm of the patient hand, looking out for any lesions, Janeway's lesion as well. I'm checking on both sides. And now I will be checking the temperature of the patient, making sure there is no peripheral arterial insufficiency in the patient. And I will be doing the same thing on the lower limb of the patient. I'll be checking for the temperature as well, just to check any insufficiency in the patient. And also at the same time, I'm looking at the capillary refill of the patient, and it should return in 30 seconds, in 3 seconds on both sides as well. I'm also checking the nails as well of the patient, make sure there is no atrophy of the nail, and then there is no shining skin, and then there is no hair loss on both legs of the patient as well. And I'll be checking for any form of edema on the patient as well. And then
I will be explaining to the patient that I will be checking his blood pressure and asking him to place his feet flat on the floor, and also the hand at the heart level. I will be making sure the blood pressure is accurate for the patient, and also now be checking the brachial artery, which is located next to the bicep tendon, and placing the blood pressure 1 centimeter above the antecubital fossa, and then in alignment with the arrow and the brachial artery as well. And now I will be palpating the radial artery, which is located at the flexor surface of the lower arm, just to get my target pressure. And once I have the target number, I'll be adding 20 to 30 millimeters of mercury to that number after I palpate the target pressure at the radial artery. Now that I can get the target pressure number, which was 120, now I'll be listening to the blood pressure through auscultation, and I'll be palpating again for the brachial artery and put the diaphragm of my stethoscope on the brachial artery, and I will be listening for the first cough sound, which will give me a systolic blood pressure. and I will wait until that sound completely disappears and the needle reaches 0, which gives me is diastolic blood pressure. Now I will be assessing the rate and the reading of the patient radial pulses on both sides to see if it's symmetrical and there is no subclavian stenosis or delay. Now I will be checking the right side of the radial pulse, which is located on the lateral surface of the wrist next to the flexor capri radial tendons, and I'm checking for the rate and the reading, and the reading is regular, and also checking the rate, which is supposed to be 60 to 100 beats per minute, and I'll be checking that for 30 seconds and multiply by 2. If the reading is regular, I would just do a 30-second, but if it's irregular, I will be counting for complete 1 minute. Now I will be checking the jugular venous pressure of the patient, which will help me to assess the volume status of the patient. At the same time, is the central venous pressure. I'll be applying the pillow to the back of the patient to make an angle of 30 degrees, and I'm checking internal jugular vein on both sides. I can't find that, and I will be able to tell between the internal jugular vein and the carotid artery. The carotid artery on palpation, the pulsation does not change, unlike the internal jugular vein where the pulsation will change. And now, because I cannot see that, I will be doing an hepatojugular reflux on the patient and also palpating on the liver for about 10 seconds. That will help to increase the venous pressure or venous return on the patient, and I'll be able to palpate that. And now I will be, from the sternal notch, I'll work my way down to the sternal angle. I'll place my ruler vertically to do my measurement, and then I'll also be placing another vertical line across from the highest oscillation points of the internal jugular vein, which will be really tutor lower to the neck. I'll have to go lower than that and then I'll be measuring, and that's around 3 to 4 centimeters, and it's telling me that there is no pulmonary hypertension or there is no aortic stenosis ongoing. And then I'll be adding like 5 centimeters to that number, making 8 centimeters, and that will be reading from like 8 centimeters from the right atrium, and that completes the jugular vein pressure assessment. Now, I will be doing the carotid artery examination, and I will first be locating the carotid artery, which is located medial to the sternocleidomastoid muscle. I'll be using the bell of my stethoscope, and I will gently place that on the carotid artery, and I'll be listening for any breath, which is a whooshing-like murmur sound. I'll be listening for that, and I will also do the same on the other side, one at a time. I will also be listening for the breath on the side, which is a turbulent flow. And now I will be palpating the carotid artery, but this time around I'll be using my index and the middle finger, and I will slowly apply pressure, feeling for maximal pulsation, and then slowly releasing the pulse. If I do not feel any trills, which I'm not supposed to feel for, it indicates there is no aortic stenosis. I'll also be noting the amplitude of the pulse, which is supposed to be strong, and checking for the contour of the pulse, and it's supposed to be smooth, and the rapid upstroke, which indicates S1, and the gradual downstroke, which indicates S2. And I will be doing the same on the other side, one at a time, to avoid syncope on the patients. Now I will be doing an inspection of the precordium, and I'm looking for any scars that indicate any form of sternotomy scar. I'm checking for pectus excavatum that is suggestive of Marfan syndrome or mitral valve prolapse, and also checking for the pectus carinatum that might be suggestive of Marfan syndrome that could place the heart downward. I'm looking at the chest for any form of retraction as well on both sides, and I'll be bending over the chest wall for any visible pulsation or eaves on the apical side. I will ask the patient to sit up while I'm checking for any form of kyphoscoliosis on the patient. Now I will be checking, doing a palpation, and I'll be checking starting from the point of sternal impulse. I'll put my hand at the jugular notch with one finger and slide it to the 5 centimeter down to the sternal angle, and then I will check for the left side, the second rib, third intercostal space, fourth rib, fourth intercostal space, fifth rib, fifth intercostal space, and I will slide down to the left at the mid-clavicular region where the apical impulse is located. And then I would, if you can't feel it, I ask the patient to maintain a decupitoid position, and that will be able to bring the left ventricular closer to the chest, and I'll be feeling for the pulsation at the apical impulse. And then now I will also be checking for the diameter of the apical impulse. I will be doing some landmarking on the patient, and it's supposed to be about less than 2.5 centimeter. If it's greater than that, then that is indicative of left ventricular hypertrophy. I will do the measurement, and now I will want to also check from the left sternal angle, and it has to be 7 to 9 centimeter from the sternal angle. I'll be also checking for the pulse impulse and the trills. Trills are palpable murmur, and I'll be using the ball of my hand, and for the if I'll be using my fingers as well to check. Now I want to also repeat that after doing my land marking again, I want to locate the third, fourth, and the fifth intercostal space. Tricuspid, and now to the fourth intercostal space and the fifth intercostal space. And now I'll be putting my fingers and I'll be checking at those 3 points. I'll be checking for any lift, eve, and the pulsation, and I'll be checking for any sustained lift, any sustained tapping, which is indicative of sternal mitral stenosis, and I'm checking for eve, lift, and pulsation. Now I'll be doing the same thing at the pulmonic area at the second intercostal space as well. This time around, there is no eve on that side. I'm only checking for the pulsation and the lifts. No eve on the pulmonic or on the aortic, and I will slide my hand down and check on the right side, which is the aortic side, and I'll be checking only for lifts and pulsation, and there is no eve. Now I'll be explaining to the patient I'm going to be percussing on his chest. Also, I'll be comparing both sides to identify if there's any situs inversus. Okay, I will be starting at the jugular notch and then going 5 centimeters down to the sternal angle and move laterally to the second rib and then second intercostal space, which is resonant. And then I will move straight across to the second right intercostal space to compare both sides, and it should also be resonant. Next, I will move to the third rib and then the third intercostal space on the right, which is resonant. And then to the third intercostal space on the left, which is dull. And then move to the fourth intercostal space on the left, where it is dull on the left and resonant on the right side. And then move to the fifth rib and the fifth intercostal space, which is dull on the right due to the liver, and then it is dull on the left due to the heart being placed there. I will percuss more laterally to the left to identify if there's any left ventricular hypertrophy. Now I'll be auscultating the heart sound and listening for high-pitched sound. I will start at the jugular notch and move down 5 centimeters to the sternal angle and firmly place the diaphragm of my stethoscope to the right second intercostal space, which is the aortic area, and then I will palpate the right carotid artery with my left index and middle finger and listen for any aortic stenosis. I will then move laterally to the second intercostal space on the left to ask the patient to inhale, listening for splitting of S2 sound. The A2 precede the P2 on inspiration. If I hear the P2 before the A2, then it is indicative of Poxer's paradoxical. And then I will move to the third intercostal space, which is the EPS area, which is where S2 is loudest, and to the fourth intercostal space, and then to the fifth intercostal space, where S1 is loudest. And then I will switch to the bell of my stethoscope to listen to the low pitch sound, which or any extra sound, S3 and S4. Starting from the apex, I'll be listening, and then I'll be listening for any mitral stenosis at the tricuspid, at the EPS area, pulmonic, and aortic area, listening for any aortic regurgitation at the aortic area. While the patient is in the upright position, I will be auscultating areas of the chest wall. I will be starting at the jugular notch and moving 5 centimeters to the sternal angle and laterally to the second ribs and to the second intercostal space, and then to the third rib and then the third intercostal space, which is the up point. And I will ask the patient to hold their breath, listen for any signs of aortic regurgitation, and then to the tricuspid area. I'm moving to the apex of the heart, asking the patient to lean forward, which brings the heart close to the chest wall, and I ask them to hold their breath using the bell of my stethoscope, and I'll be listening for Austin Flint murmur.